Hello and welcome back to GI 101. My name is Dr. Adriana Lazarescu, and I'm a gastroenterologist at the University of Alberta in Edmonton. With me in the GI 101 studios today is my co-host, Dr. Dan Sadowski. Dan, have you brought a case to discuss today?
Well, yes, I have.
Okay, let's get started.
So, this was a 55-year-old male who was referred to me for assessment of heartburn. And he's had this problem for at least the past 10 years, but it has been worsening recently. And by heartburn, he describes a rising sensation of painful burning from the upper abdomen into the chest, particularly after meals. And with burping, he will often note the regurgitation of bitter-tasting liquid into his mouth. And more recently, the burning pain has been waking him up at night. And on occasion, he has had to spend the night sleeping semi-upright in a reclining chair.
Has he had any difficulty swallowing?
Well, he hasn't had any dysphagia, and his appetite has been excellent. And in fact, he's gained 10 pounds in the past year after his retirement.
Are there any other lifestyle factors to consider here?
He does smoke a half a pack of cigarettes per day and does tend to drink several glasses of wine each night with dinner. I should also mention that he's otherwise well. On physical exam, he is slightly overweight with a BMI of 30.
Has he had any treatment to this point?
He does tend to self-medicate with Tums, which does give him temporary relief. And previously, his family physician had given him an H2 blocker, ranitidine 150 milligrams twice per day. And this initially gave him some relief, but more recently it hasn't helped all that much.
So what do you think the diagnosis is?
Well, given the rising sensation of acid, particularly after meals and with recumbency, along with the prompt relief with oral antacids, I think it's a high likelihood that he has gastroesophageal reflux disease.
Are there any diagnostic tests required to make the diagnosis of GERD?
In the setting of typical symptoms like this, I think the diagnosis of GERD can be made by history alone. Other symptoms that are often seen with GERD are regurgitation into the mouth, particularly with bending over, nausea, water brash, which is hypersalivation with heartburn, and globus sensation, which is a lump feeling in the throat. GERD as well, in some cases, can be complicated by other issues such as cough, dysphagia, or non-cardiac chest pain, and in those settings, further testing may be required.
Would you do an endoscopy at this point, Dan?
Diagnostic testing with endoscopy is usually not required to establish the diagnosis of GERD. However, endoscopy is indicated in several situations, particularly in the presence of alarm symptoms. And by alarm symptoms, we mean dysphagia, bleeding, anemia, weight loss, and recurrent vomiting. As well, endoscopy is recommended when GERD symptoms persist despite an adequate therapeutic trial of PPI for 4 to 8 weeks.
So why do people get GERD?
Well, that's a very good question, and as you know, GERD is probably one of the most common GI problems to affect the human race. So I think it is a good idea for our listeners to have a good understanding of GERD pathophysiology. The common misconception is that patients with GERD have a problem with too much gastric acid. But in fact, GERD sufferers have the same degree of daily acid secretion as non-sufferers. The problem is that the gastric acid finds its way into the wrong place, that is, into the lower esophagus. And it turns out that the esophageal mucosa is very sensitive to the presence of gastric acid. And for that reason, there is an elaborate barrier function that is designed to prevent the reflux of gastric contents into the esophagus, while still allowing the antegrade passage of food and fluid into the stomach. One of the main components of this barrier is the lower esophageal sphincter. This sphincter muscle is closed most of the time. It does open briefly to allow the passage of a swallowed food bolus, and then it quickly closes again. In GERD, several abnormalities can be seen with the lower esophageal sphincter. There can be a low resting LES tone, or you can have spontaneous, transient relaxations of a lower esophageal sphincter at inappropriate times, allowing reflux into the esophagus. There are a number of lifestyle factors that promote both a low resting LES tone and increased frequency of transient LES relaxations. These include nicotine, caffeine, and alcohol, and certain medications such as anticholinergics, nitrates, and oral corticosteroids. The presence of a hiatus hernia and increased BMI can also further inhibit the function of the lower esophageal sphincter. As well, there are other factors that contribute to the persistence and the severity of GERD, such as delayed gastric emptying, altered esophageal peristalsis, and hyposalivation.
Is GERD just a nuisance condition, or can it lead to more serious disease?
Untreated GERD can actually lead to fairly serious disease, such as the development of peptic esophageal stricture, erosive esophagitis, and even Barrett's esophagus, which is a risk factor for esophageal adenocarcinoma. GERD as well can be associated with chronic cough, asthma, and aspiration pneumonia. More recently, it has been recognized to be a major cause of altered sleep.
So what would your treatment approach be to this patient?
Well, in GERD treatment, there are currently two main approaches: step-up versus step-down therapy. By step-up, we mean initial therapy with counseling regarding lifestyle factors and an initial trial of modest anti-secretory therapy with H2 blockers. By step-down therapy, we mean starting treatment with a strong anti-secretory drug, such as a proton pump inhibitor, and then stepping down to the minimal dose required to maintain a symptom-free state.
Is there any evidence that lifestyle factors actually work?
While I do routinely recommend lifestyle modifications, there is actually very little scientific evidence to support this. In fact, the only lifestyle measure with supportive research evidence is weight loss, and also elevating the head of the bed at night.
Did you give this patient any drug therapy?
Well, given that he has already tried and failed medical therapy with H2 blockers, it would be entirely reasonable to start him on a proton pump inhibitor. So I did start him on a PPI, pantoprazole, 40 milligrams once daily.
And how did he do?
Well, on his return visit 8 weeks later, he did note some improvement in his symptoms, perhaps a 50% reduction in symptom severity, but he still had reflux problems, particularly at night.
Did that surprise you?
Well, not really, because we do know that up to 30% of patients with GERD symptoms actually remain symptomatic on once daily PPI.
So what did you do next?
Well, in this setting of non-response to once daily PPI, I would do an endoscopy to rule out erosive esophagitis, Barrett's esophagus, or other diagnoses. And in the case of this patient, I did the endoscopy, and in fact, it was completely normal.
So what do we do now?
Well, I think that's a good question, and perhaps we should talk about the management of PPI refractory GERD next week.
Okay, why don't we do that? This concludes this week's episode. See you again soon. Bye.